moving services out from acute hospitals into the community. And that has changed funding streams, which means money's going out into the community so people can do things differently. And obviously we've talked about the older people demographics. Tell me if there's a question here. So one of the projects that we've looked at, one of the papers, it was a Kingsman Project, which looked at people coming into hospital and calling ambulances and other emergency services. And basically patients were teetering on the edge of managing. And what we found from this work was that older people often could have stayed at home when they were transferred into an ED department if certain things had happened at that point. So we started to say every contact counts. So could a GP visiting made a difference? Could a district nursing team made a difference? Why weren't they accessed? And actually, why was the ambulance called? Well, the ambulance was called a 999 ambulance because no one else knew what to do. So we felt that was the starting point. So I'm now going to talk to you about one of the first projects that we've looked at. And it's looking at, sorry, this slide comes in here. So we looked at this, improving urgent and emergency care for people, the right place, the right person, starting in the community, right through into the hospital. So making those changes before we start doing a great deal in the hospital. We've talked about that. Okay, so the Acute Geriatric Intervention Service. In East Anglia, which is that big green bump that I showed you where Queen and Prince Philip live at the top, right the way round to the bottom, there are 3 pilot sites of Acute Geriatric Intervention Service. And this has been funded by the ambulance service. The ambulance, there's a designated ambulance which is kitted out with Zimmer frames, walking aids and point of care testing so they can do biochemistry, blood works at the site of the home. And also they take out with them a physio, an OT and a paramedic that's trained in advanced assessment for frailty. The calls are intercepted through the 999 or the 911 as you would know it by a group of specialty people within the hub, and they intercept the calls. Now the calls could have come from a GP who couldn't visit and just called the ambulance, from a neighbour or anyone else that's called the 999. So they're intercepted through that. They are then have more detail about the call, and then they dispatch a non-blue light ambulance to the call. This team will go out and then they will assess the patient, and if they feel that after some point of care testing, so they may do some baseline blood works and other physical, functional and psychological assessments, and considering the family and social workup, they feel that the patient can stay at home, then they can then initiate various things. So alongside the walking aids, they can access to night owl care, so increased carer support, and 6-week stay-at-home packages, which is all part of this. They can call the GP out, they can book GP appointments, they can access other district nursing teams, people to address wounds, and it stops the conveyance. And this is proving really successful. It's small numbers of patients, so when we looked at it statistically, it doesn't show a huge number of patients being stopped from conveyance, but what it does show is those patients wanted to stay at home, and actually once they come in will be one of the patients that could stay 3 to 4 weeks and could end up with being one, as we call it, a detox of care.
Yeah, Suzie, it's Ken here. I just wanted to interject with a question. This is a really interesting idea to me. It strikes me as a senior-friendly ambulance, an ambulance that has equipment to provide for function and for assessment of the elderly, as well as a team-based assessment service, as well as linkages to other services in the sector. Is this at a project pilot stage, and if so, what are the outcomes that are being shown, or is this a durable, sustained service at this point?
No, these are pilots. It started with one pilot up in the top part of the green bump, and it showed that it made a difference in terms of conveying 5 patients a day that would have otherwise come, which doesn't sound very much, but actually 5 more complex patients with one small service. So the service was working from 8 till 6 Monday to Friday, and it was averaging, as I said, 5 to 7 patients a day. So they decided from that it was a cost of £150,000 for the ambulance for a 6-month project on top of the normal working. of the ambulance service. So they've now cascaded that out to 2 more sites. So the pilot is extending until April next year on those 2 sites, and then it will be evaluated. In the long term, it's quite a costly exercise, but benchmarked against, as I said, the cost, which isn't always quantifiable, of the long term, because we don't know if the patient would have stayed in 4 weeks or 6 weeks, but it's actually looking at patient and carer satisfaction. It's looking at sustained care at home by increasing early intervention sooner. Hopefully, this would build upon GPs and primary care teams actually identifying those needs before this ambulance is called in, and looking at it in a wider picture that should be addressing those projects that are coming up, which are also there. But I think, no, it's not sustainable in terms of, it's not sustained financially at the moment, but I think it will be. I think it's going to be integrated with ED. So we're looking at how it works and interfaces with ED, and also taking people home as well. So,
wonderful. We'll look forward to keeping in touch and hearing about that.
Thank you. I'll carry on. Please ask questions as I go. So we have frailty assessment projects that I was going to speak to you about. Firstly, about the one in Suffolk, and if time, there's a few questions, a bit more information in Norfolk. So our focus was really to try and say, what can we do in terms of frailty assessment right at the front door in the emergency department? And I don't know if any of you are from the emergency department, but this was about really from triage, so that triage patients will come in, they'll be either walk in or they'll come in by ambulance. And what tools do we use to assess patients at triage, so that that could trigger some of the resources that might be needed at a soonest point, rather than waiting maybe an hour and a half until they've been seen by someone. And going back to, as I said before, we have a 4-hour window. So the first 5 minutes of the journey are equally as important to 3 hours down the line for us. So we looked at tools of assessment and triage and tried to think, what could a triage nurse do, which is already a very comprehensive assessment, that's as quick as possible to identify if there's a trigger for further assessment by the teams. So we have something called the Bournemouth criteria, which is just 3 points. Is a patient 90 years or above? Are they 65 years and above from a nursing or residential long-term care? Or are they 75 years and above with 2 or more pre-existing conditions? And they're conditions like falls, confusion, incontinence, and the other sort of ones that we're familiar with. So we used that as one of them. We've also used, we did a project where we looked at ISAR, which was an audit project where we put the ISAR, Identify Seniors at Risk tool, in the triage, and we had 100, we tried it for 100 patients and reviewed, and found that actually it didn't give us in the UK the clear triggers that we needed, but we tried that one. We also have Rockwood, which you're all familiar with. And we wanted to say that if we use a trigger tool, it identifies a certain score that would trigger a frailty team and interventions at the soonest point. Ambulance patients would move to a seated area, and the trolley patients would still carry through the trolley area, and they would start a further assessment at that point. Staff were trained in identifying, and as I said, we used the Bournemouth tool, where we are now, identifying in using the Bournemouth tool, and also considering the delirium pathway right at the beginning of the assessment. So we've looked at this tool, which is ThinkFrail and triage, as well as the Bournemouth tool, and this was again yes to any of these complex multiple conditions, falls in the last 3 months, as you can read for yourself, any of the usual things that we're looking at. If the patients said yes to any of those things, which was quite easy and simple at triage, then they would go on to a secondary assessment, which was slightly more comprehensive, which you can see here, and that was ThinkFrail. So this second stage is in areas where patients have a little bit more time, where the clinicians have a bit more of a one-to-one focus with them, not actually in the triage. My focus as a consultant nurse was to change people's thoughts on triage and make it a useful assessment rather than just a sifting and signposting. So it's useful, and they're signposted to the most appropriate place rather than just into a queue where they're waiting for time order or even clinical need, because that all goes along anyway. This was about using other skills within that time window while they're waiting for either a practitioner or a medical assessment. Is that okay? Okay, so we have also the delirium pathway care bundles, which I'm sure you all have. It's been a large push again to get these integrated as soon as we can at the beginning of the patient journey. These patients with the delirium pathway are usually admitted to the acute beds, but what we wanted to do is stop the delays in all the interventions and consider the early initiation. So we try now in the initial management on focus 1 to 10 that the patient should have that stage started within the ED. And again, we're talking about a 4-hour window that we focus on. And the feeling with that within the staff and training them is that if they move to some of these, and not all of them, that's good, but it's not about waiting till they move somewhere else. And the delirium pathways are complex, and if anyone's got any ideas on how you simplify them for an ED department to start them and be successful at integrating it into daily practice, I'd be very pleased to hear from you on that one. Okay, so I'll tell you now about a service that we've set up, which really looked at trying to use existing resources within the emergency department and the hospital to identify senior patients that could be treated in an alternative setting, which for us was a focus on moving them out of the 4-hour window. And it was also about looking at patients that could have access to geriatrician and specialist service from the community that otherwise might be sending their patients into the emergency department because they could not wait for an outpatient appointment. So this is now the service that I'll share with you. And again, please ask as you go through. So we had 2 services which commenced in October 2015, and they were pilot services. They are now substantive services, but these were both pilot. And they were developed on something called winter scheme fundings. And I'm not sure if you have that here, but we have annual funding of winter schemes, which is really pushed towards trusts and acute hospitals to develop services that can address the winter increase of attendances to emergency, particularly around doing things differently. The idea of the funding is it creates some front loading to enable people to think differently, and after that money's gone, they'll be able to carry on with the service, which is challenging, but it happens every winter, and we move into it every winter with the gusto that we should. So we had a community-based crisis response team, and we developed a hospital-based comprehensive geriatric assessment service, which I'll tell you about both of these. And both of them had direct access from alternative places, but not from the emergency department, and they both worked independently. So the frailty-based assessment team is called FAB, and the service description of this, it's a comprehensive geriatric assessment with a focus on acute issues. And the focus on acute issues means that sometimes in ED we see this patient that has an acute exacerbation of a medical problem in frailty that could be assessed and dealt with on the day, but isn't due to the fact that we do not have access to that specialty focus within the service. And also GPs or see patients, or other community health providers see patients that may want a geriatric specialist assessment on the day or within 48 hours that they didn't have access to. So this service was set up, it was set up for multidisciplinary rapid assessment, and within 48 hours from the community bases and same day from ED. They took their referrals from the GP, community teams, the emergency department, and it was phone directed to the consultant on call or an email if it was out of hours. And the service was initially from Monday to Friday, 8 till 6. The service consists of a consultant geriatrician, two nurses who look after the service, the base, the FAB base. It's had investment into designs. It's senior friendly designed. It's beautifully coloured. I should have some more pictures, but it's very nice inside. 2 physios, 2 OTs, and a therapy assistant practitioner. These are the people who, I'm not sure if you have them here, but they're non-registered, but they're trained to support the therapists in delivery of therapy and assessments. one healthcare assistant, which is a similar kind of person, do all your phleb and bloods and ECGs and workups, and Suffolk family carers. Now, there's been lots of work in the UK on the integration of families and carers into the delivery of acute care. And this is quite interesting work, and it's come around a lot about from the dementia work, where we've integrated policies that enable families and carers to come to hospital with the patient with dementia and interface in the care into a level of care as much as they choose to. So from personal care, feeding, to being part of the ward, to helping. And this has changed the way the acute service has looked at the integration of carers. It's developed a carer service in each hospital, and each hospital has like a carer cafe or a carer bus, where carers can go out at lunch times and talk to other carers. There's signposting, there's mental health wellbeing, accessed aged services in there. And a lot of it is about recognising the carer workforce and keeping patients at home and out of hospital, and actually when they come in, supporting them. So it's lots and lots have happened with this in the UK.
I was nodding, and I think I caught Susie's attention because I had a question about the family carers. Is that a volunteer-based program, or are they remunerated community members?
No, the family-based carers are family members or close members that actually provide care, and they're the family members.
Oh, I see.
Yeah.
Engaging the patient's family
Engaging the
themselves.
patient's family, or the patient's dearest and nearest. It's not necessarily. And the way that it's changed is that the hospitals have taken a focus on supporting these people, as well as supporting the clinical care for the patients, as they've recognised the enormity of what they're doing in the community to keep people at home and manage. So I suppose, in summary, it's listening to their voices more. Their voices are heard when they say something's wrong. Their voices are heard when they want to come in and help and contribute to care. And it's actually changed policies, procedures. The way we work on wards is completely different in the last 5 years in terms of engaging family and carers than we ever did before.
Yeah, and I don't want to hijack your presentation, but just along those lines, have you received feedback from the family members that they feel any different in terms of how they receive care, like better engaged, more confident with care as a result of this program?
Yeah, we have a national survey that goes out every single day to patients in hospitals, which is directed by the government, and that part of that is on carers and their engagement, involvement in family care, and that's significantly risen over the last 5 years since we've been doing that, hugely. Wonderful. Emergency departments find it very difficult to get feedback on that because they're so busy. They have a 20% target to deliver feedback every single day, 20% of the cohort, and there's been lots of work done around trying to get that cohort of responses back, and that's because the transition of those patients through the emergency department is actually only 4 hours, 95% within 4 hours. So catching people's experience at that time on a national survey has been difficult, but we've done local implementation of how it looks for the emergency department and engaging carers in patients with resus in all their healthcare needs and being involved from the beginning. We don't leave them in the waiting room anymore. So it's made it very hard for us to work in our cramped conditions, actually, with having families in there. But it's a plus. It's definitely a plus.
Thank you.
So that's the team. So the crisis action team, which was the other part of the teams that were brought together, was a 24/7 multi-agency team, which was health, social care and voluntary care. And this looked at supporting adults experiencing a crisis at home to remain in their own home, and a rapid discharge from the emergency department to prevent an emergency admission. So these are simple things like putting in care packages for people at home, and we also have something called virtual ward. So people could go home that might need nursing care at home, IV therapy, wound care, drains. We could get these people home with virtual ward. So virtual ward is like a 25-bedded hospital, but it's virtually carried out in the community, and you can fill it up with patients on a continual basis. And that, again, was started from winter monies that interjects into this crisis action team. And they would arrange transport for people to get home, increase care support, emergency admission to respite long-term care, All very important things around turning patients around and getting them home without an acute admission, and also about keeping people at home. So these are the two services, and both services worked in silos. And they again had a similar kind of workforce, except if you note here, they had a British Red Cross staff team, which is a voluntary team, and they would go home, they'd take bread and milk for patients, they would go home and sit with patients while they're waiting for a relative to come, or they might do something we call a night owl service. They'll make sure patients are tucked up in bed waiting for the carer the next morning. So that's been a huge big surge of work. Yeah.
I notice a question coming from Maria. Maria Boyce, is that you? She thinks the FAB team's a fabulous concept. I'm sure you intended that, Maria. Let's hold on to your question, though. Maria's asking about care coordinators to bridge with the community, and I know that's part of your presentation. So let's leave you on a bit of suspense, because the answer to that's coming, Maria. But if you could hold on a bit, maybe stay on to the end of the presentation, and we'll hear more about that in a little bit.
Okay, so the service challenges led to the need for this new integrated service. So limited integration and missed opportunities in A&E, which is emergency. So the other word for emergency and ED is in the UK is accident and emergency, which is kind of outdated, but it still slips in. So the new integrated approach was to have ED at the top, be able to refer straight to CAT and to FAB, and for the two to refer together. And that was the first aim of pulling those services together. So how did we do that? We employed a geriatric interface nurse, which is the coordinator, experienced general geriatric nurse who had been a ward sister, ward charge on many geriatric departments, worked in other hospitals, really proactive, doing her advanced practitioner program that was appointed in this position. And basically she has really, we don't like to say we have person-driven services, but I often think it's personally driven when they start, to give that enthusiasm into something. So this is Renee, and she started in 2016, and she does the proactive case finding. So she also supports safe, appropriate discharges and admissions from the department. And she is the CAT and the FAB liaison. So they call her the FAB CAT. And she found it very difficult initially when she first had to go into ED, because ED are quite territorial. I'm sure they're not in Canada, but they are in the UK. And she sort of had to gently push into ED to say that she was there to actually get patients out quickly and take them to a more appropriate place where they could have time for an assessment. And the minute people found out what she was about, they were kind of grabbing her. So she went from having 1 or 2 patients in an 8-hour shift. So she has a queue now. When she gets in the morning, the overnight patients are all ready, waiting for the FAB to be taken down to FAB or to have CAT interjections with them. So that's been really good. So that's simplified really, a lot of hard work over the last 6 months. But what we looked at to assess the impact was the positive patient experience, the good stakeholder engagement and the feedback and the admission avoidance. So as I said, GPs could refer into FAB, and that was something a lot of GPs when we first started said, well, it's okay, we can wait for appointments, we're already doing all this. So it was interesting to see how they uptake on FAB was when they started. So the patient experience, as you can see, there's some quotes in there, but it was 99.6% recommended for FAB and 100% for CAT. I mean, that 0.4% might be because the CAT patients probably stayed at home, and 4%, 0.4, but minimal. So total of 246 responses for FAB and 74 for CAT. All, extremely likely to recommend is the biggest surge. And obviously this opens our doors to, whenever you open a new service, there's this surge of unmet demand as well coming in, which we've noticed as well with that. So you've got, people really liking this service. My feelings on that is when you take people out of an emergency department, and we look back at the picture where they're lined up in queues, to an environment that's designed for them, where people are specifically picked and educated and trained with a focus, and the geriatrician specialist input is in there, people are getting a good service, and the people that are there are able to provide the service that they really want to. So, you know, you would hope that we would get this feedback, but it was excellent that we did. So stakeholder engagement, we had from the GPs, one of the quotes is, "I didn't think you would add anything to what I already knew, but you did, and you have really helped manage my patient." So that's just one patient. And thank you and the team for the fantastic level of support. This has maintained our independence, reduced the risk of muscle bulk loss, hospitalisation is at risk of causing. And this service has been invaluable to an MAU consultant. So we had the medical assessment unit using the FAB, we had GPs using the FAB, and we've had ED using the FAB, and everyone thinks it's FAB, which is great. It needs to grow. It's now sort of, as I said, the demand is higher than the capacity. So the impact, which everyone wants to know about, is out of 931 patients that were assessed, 90% have returned home. 31% of them home with some small changes, 3% were stepped up to other care initiatives, and 7% were admitted to acute hospital. So 7% of the patients that were taken in there, either via the GP or ED, were admitted to hospital. And we haven't looked at how long they were admitted for or for what reasons, but we do have that information. So all of them had a comprehensive geriatric assessment, which you understand here too. And one of the things that we've tried to do is start that in ED now, particularly out of hours and overnight when we don't have access to all these wonderful services. So we've tried to get that focus in ED, which is really useful. 81% admission prevention at 30 days. So if you're looking here, we looked at 30 days people that were staying up to 30 days beforehand, and 81% of those had a prevented admission, so that was good.
Yeah, we have a comment from the audience, Kay McGarvey.
Yeah.
I think they must think this service is fab as well, but they're asking if there are programs for perhaps younger patients who have disabilities similar to the needs of geriatric population, but maybe don't make the age cutoff, or is there flexibility in these programs to see younger patients?
We have other assessment units which focus on younger patients. So patients with learning challenges will still be in the age-related assessment unit. So we have surgical assessment units, medical assessment units, and paediatric assessment units. So those areas will focus on the age-related and medical surgical conditions and have a similar focus. But what I would say is the multi-professional focus is far more developed in geriatric medicine than in any of the other areas. So there is room and work to do in those areas, I think.
Yeah, and I think that comment speaks to really a foundation of senior-friendly care, is that it's good, thorough care, and that younger populations that have vulnerabilities benefit as well. So oftentimes it's good care for everyone.
Yeah. And I think one of the things is just changing mindsets. So if we can use a model of multi-professional care, and also it addresses many of the things around the workforce challenges that we have in medicine, in nursing, and in other professionals in the groups. So if we can use a combination workforce, which has got to be better because it's looking at all parameters of the person more holistically, it's a win-win, because it puts the patient in the centre, it blends the professions, and it moves patients through a system that's less clunky and clumsy when it's segregated out into services. So yeah, I mean, it would be brilliant to do that, and I think work is going on, but not to the same extent as it is in older care. So integrated services fully operational from the end of September, and it showed a clear reduction in ED attendance to the medical conversion rate. So in our 4-hour performance, we're also charged with a conversion rate, and a conversion rate is which I'm not sure if you call it the same thing here, but it's the amount of patients that we admit from the emergency department every day to a hospital bed. And we should keep our conversion rate to under 25% of all patients in the cohort of all patients. And we found that was creeping up hugely. And as you know, once the 4-hour window doesn't give us time to make decisions about some patients. So those patients were becoming an admission. So this is where this group focused. It was taking the admission cohort into an area where they could spend more time, the appropriate resources within their appropriate facility to ensure or to work towards a discharge rather than admission. And that's how this has shown the work that's changed the ED medical conversion rate. And as you can see there, it's gradually coming down. It's the dark blue line on the ED attendances from the pale blue. Equally, this has come down on the backdrop of attendances going up. So it's actually, more impressive than it looks. And also, I think the other people forget, one older person's admission takes a lot longer than one person admitted to acute medical ward that's 45 with one problem. So if we can make a difference on this, it's significant in the time days that are spent in hospital afterwards that we have got that data for. So a little bit more data there against a backdrop of 9% greater ED attendances. That's the figure there. The service yields 5.5% greater ED discharge rate and 7.9 lower admission rate. So that's on the backdrop of the 9%, which is good. And those figures here, which one of the doctors put in here for us. Okay. So integrated admission avoidance service benefits delivered. This is in terms of costings here. We're looking at obviously pounds, and the overall costing for the CCG, that's our community GP consortium who commission acute care. So our funding sits in community and cares commission by them. They fund the acute to provide the service. The savings for them was 260k on this project. And the trust savings, which is the acute trust, that's what we call it, was 177k. So that's based on the 80% admission avoidance of a 5-day length of stay. And that's quite, 5-day length of stay is not common for lots of the older people. It's much longer than that. And a saving based on 2 lengths of stay, which was the overall one. So significant savings in that first project, and bearing in mind that the project was really just a cohesive working of service and an appointment of one extra band, senior nurse in that to pull it together. But it has opened unmet demand from GPs particularly and from the emergency department. Okay, so staying ahead of the emerging challenges is already expanded the FAB to six assessment areas. So it had 4 to start with, it now has 6 bays. We've already done the proactive emergency department case finding, which has increased the workload in there. There is extra resources now to move this to 7-day working and to look at implement telephone patient follow-up, where we also hope to implement a carer satisfaction survey and a patient satisfaction survey, as well as a clinical focus on the follow-up. Further training of staff required. We need an expansion of staff to manage the 6 FAB assessment areas, and the demand is increasing. We have real challenges with the IT interface as well, and I'm not sure again how it is here, but every community system, every GP surgery and every hospital uses a different IT platform. So the IT platforms are clunky and slow, and that has an impact on service provision and actually also on data analysis and looking at outcomes and other service transformation design. So those are our next challenges going forward.
So we have a question. I think if we take a slight pause there, I think that's the end of the Ipswich story, isn't it?
Yeah.
So we have a question, but before we go on, I propose a bit of a vote. We have 13 minutes left, which we can spend on questions and discussion. Otherwise, we have another story we could tell about the service in Norfolk, which integrates many of these services into a hospital-based program. Would you like to, if I put forward a motion, and if someone will forward that motion and someone else will second it, we'll move forward with that to continue with the Norfolk story versus wrapping up with, maybe 10 minutes or so of questions. Would anyone like to hear about Norfolk? We have a number of people. Norfolk, seconded, there we go. So why don't we answer the question, which is about patients, your ED discharges. Do you find that a number of those, or a significant proportion, are transferred to palliative or hospice care? Or are these patients mostly going home to the community?
The ED patients that are transferred out, if it's palliative or hospice care, they would need to come into the acute hospital firstly, unless in one of the EDs there's a 24-hour stay, so you can stay there and they would be transferred out. But getting palliative and hospice beds from emergency is very, very difficult. The work, conversely to that, has really been around keeping people at home on palliative advanced care plans, and there's been a lot of work done on that. So most patients now, particularly in Suffolk more than Norfolk, have a yellow care plan, which when any provider goes in an emergency situation, ambulance, GP out of hours, any of them, if this care plan is in place, it enables those patients to stay at home with some add-on, which may be just in case medications, it may be access to the hospice care, carers at home, overnight stays. So those patients will not be transferred. If a patient is transferred into ED, and it's happening, of course, for end of life, where possible, if it's imminent end of life, they will stay in the assessment in a special area we have on ED for them to go to with the families. And if not, they will be transferred up to the wards. It's not ideal, and if the patient doesn't come in with an end of life plan or the do not resuscitate plan, it can be very challenging. And I'm sure I have read quite a bit about that within your settings and in America as well, that is an extensive problem across all our services, that sometimes things change or patients deteriorate last minute and they come in ED. And in all honesty, it's not ideal. But it, as I said, from the Suffolk programme, it's improving where patients are kept at home and not transferred by ambulance services at a last minute gesture.
Great. So in the 10 minutes that remain, could we maybe spend 6 or 7 and move relatively quickly through the Norfolk story?
Okay. The Norfolk story, small DDH with 400 beds and 65,000 emergency attendances a year, and 40% of those are aged 75 or over, and 60 or so ambulances a day. The conversion to admission was 28% higher than the average 20% from the emergency departments to the hospital bed, and a rural location with transport challenges. So a lot of it was about people not being able to necessarily get home, or again not seen in time. So we set up a rapid assessment team in ED, and they are fondly known as the RATs. Which they now respond to very well, and they provide admission diversion and early supported discharge home to care and outpatient settings. So it's a similar focus to FAB and CAP, but it's all based in ED, and it's been very successful. So they proactively source patients, and they have direct referrals from ED. They base themselves in ED, and they look at every presentation on the computer that's age 65 or over, and quickly introduce themselves to the patients and do a quick triage score, which they use their own tools for. And they look at naming, going in and identifying if there's anything they need to pick up very quickly. And as I spoke of having all these different systems, IT systems locally, they have access, this team have access to all the systems. And that helps hugely because they can look at past medical history, a lot of the things that we have no access to in ED apart from within the ED hospital notes. So that proves really important on trying to get people home, and I would say that's one of the biggest successes. So there's been a huge demand on service that we've talked about within the other areas. And one of the things they've found is that they've helped increase risk-taking, and ED clinicians have become very risk adverse in litigation, and a lot of patients are brought in because, one, they don't have access to all the pre-hospital and the community notes, so they think it's safer. So this team has actually helped the discharging, which are the nurse practitioners or the ED clinicians, medical clinicians, make more decisions about sending people home, and that's been useful. That's an evolution of the service. So There's some figures here which just show that in April they started, and if you look here, they had numbers of 230, 235, 230, and they've gradually developed the team, and this last year they've, as you've seen, those numbers have gradually going up and probably over doubled. Their discharge rate has not necessarily gone up, but they're taking more complex patients, and their admission rate is roughly the same, although it has gone up in some areas. But what they're saying is that they're taking more complex patients into this service, so their admission rate has changed. But their discharge, a lot of the patients that they actually look at, they weren't calling as discharges because they didn't have to do anything. So their screening patients weren't counted in this discharge element here. And that's probably something that wasn't captured, which we should have captured afterwards. Just another screen to show here that the work that they're doing, but I'll whiz through that because the average length of the stay here. So the average length of assessment time was 115 minutes, which was pretty good, because remember they had the 4-hour window to do this in, so they had to pick patients up from triage, work cohesively with the clinical decision maker, either the nurse practitioner or the doctor, do the assessment, and then make the decisions about the patient within that 4-hour window. And they're like rats. They don't want people to come in. They had a bit between their teeth. They want them to get home if they can. So they found that 7% of the patients went to alternative venues of care. 28% of the patients in the cohort they looked at required some form of formal care, so that's increased care at home. And 4% declined or didn't want anything, and 61% of them went home with some form of referral. And that just may be Age UK, befrienders, a voluntary service. So they have access to all those services that we didn't have. So what are we providing for patients? They do the multifactorial comprehensive assessment. They do the CGA at the very, very beginning of it. So if it's needed later, it can carry through. They help inform decision making. So they talk a lot to patients about making decisions about power of attorney and future planning and living wills, which patients often do not have in place. So they start that discussion with them. They make referrals onwards, and they ensure safe discharge to home. Sometimes we felt that we might see a patient, I might have seen someone and I didn't feel they needed any intervention from them, and then they would come along and say, no, actually, we need to see that patient. And I would think, oh, okay, have I missed something? But it was actually because their holistic focus was so good. They were addressing things like living wills, like neighbours in place, like the milk and bread, which I would have thought, that's okay, they can go now, someone else will do that. So that was really interesting. You know about the CGA, which is our gold standard, and the same as yours. We're trying to bring that very much to the front door, and that's what they've done. And here we've said it's got to be a lightning learning to CGA. So we've started to try and actually really, really focus this single assessment process of making every minute counts, and that's just something here that the emergency medicine overall are doing.
Suzie, if you could go back to the last slide, and there is a question coming in too. I just want to point out to our audience, those YouTube links, actually the one after that, the YouTube link, is that a training video or more of a just sort of a what is this video?
It's about the comprehensive, the frailty assessments, those are. They're not training, they're information.
I see, right.
Yeah. But this one's a module here. This is a CGA module.
Oh, I see. Yeah. And is that available to all?
Yeah, they're free as well.
So that's it. So we'll be sending out the slides and links, but definitely for people to look at some UK developed training modules on CG. There's a question from Kelly, and she's wondering if any of these teachers, the Suffolk and the Norfolk, if any of these centers are teaching facilities, which may have had an impact on the time to assess.
In all honesty, no, they're not. Both of the hospitals that I've spoken to you about are hospitals that have developed these services because they are not teaching hospitals, and they have less access to all the resources that the teaching hospitals have. So they've actually managed to do this by just pure refocus of how they work rather than anything else. Is that what you meant? Yeah.
Great.
So no extra resource in there, just literally a redesign of process.
Great. So let's continue on while the questions are coming in.
Yeah. So in summary, this team have brought to the front of the ED these questions. which again should be right from the beginning, from the triage. What happened to the person before? Who knows them and who can tell you more about what happened and who can help get them home? And what's changed? Because we've found doing this work that often ED clinicians, particularly the junior doctors and the junior nurses, they want to fix everything and make it better. Well, actually, it was fine anyway. These people were doing those things anyway. Nothing has changed, and it isn't going to change. And this team has really brought the focus in that. What they have done is help us see what available resource and support there is in the community, including voluntary, including everything that we didn't know about. And that becomes more at our fingertips 24/7 now. And looking at mechanism of attendance. So we look at mechanism of injury, but what was the mechanism of attendance? And that becomes really important. And again, that focus of thinking CGA at the front door. And this whole thing goes around the social history, and the functional ability of patients to return home is really important, and what social network they have. These two hospitals both engulf or encompass a huge rural community. And that's very important in considering social history. So that's really the summary of that. Again, they're looking at extending. They need more funding for weekend working, and that has happened. Looking at working with the bigger hospitals, exploring more rapid access frailty clinics. So this kind of team, if you consider this, they're looking at how they could access the clinics of FAB and CAT, whereas FAB and CAT don't have this service that would be pulling through to FAB and CAT. So if you had all three things in the one place, it would be perfect. So that's summary.
Thank you. Are there any, we have just a last few seconds, but if there are any questions or comments, we welcome for you to type them in. I'll keep droning on as you're thinking of your questions. So you'll receive an evaluation along with the slides for today's presentation, a link to a recording. Our next presentation is next Tuesday. Also from the UK, Brian Dolan will be talking about end PJ paralysis and an early mobility campaign that he's engineered across the UK and in fact across the world through the benefit of social media. We'll also be presenting on the Senior Friendly Care Framework in early November, and we have another webinar in the works on patient and family engagement in the design of care in November, December of this year. If you have any questions, you can contact me as well. Suzie is staying with us and visiting partners and colleagues across the GTA and Southern Ontario for the week. If any questions arise from your review of her slides or you think of later, please email me at that address. I'll be happy to forward to Suzie. It's likely not a long distance call, and she can provide some answers to further queries that arise. Other than that, I really want to thank Suzie. It's clear that there will be a good exchange of information across both directions of the Atlantic. I want to thank her as well for presenting while recovering from jet lag. And if she is an out-of-country person that had any notions that we live in igloos here in Canada, I think we've done a fantastic job dispelling that, because we were in a heat wave. And in fact, I mentioned at the beginning of the presentation that we disabled our air conditioner unit in this office, and within 20 minutes it heated up like a pizza oven in here. So we thank Suzie for presenting in this environment as well. Thank you all for attending. We look forward to seeing you next week on Tuesday. I'll resend the registration link so you can all get prepared for that webinar. And we hope to see you again and engage in more thoughtful discussion. Again, it's Ken Wong on behalf of the RGP of Toronto team and our guest Suzie from the UK. Thanks for tuning in.
Thanks, everyone.